Hello, welcome to our NOSM COVID-19 weekly clinical rounds. I'm Dr. James Gertson, a family physician and Dean of Continuing Professional Development at the Northern Ontario School of Medicine. Our focus with COVID-19 clinical rounds is to provide you with current and relevant information for managing COVID-19 in Northern Ontario. As we are about to start rounds, I'm going to just take you to our COVID-19 rounds website, as it's a hub for lots of information. This is the site that you came in today. And just a reminder, the evaluation for today is a link over here, and we encourage you to complete your evaluation at the end of rounds. And that's the way you can register for your study credit certificate. And we'll keep track of your certificates over rounds and then forward them to you as a compilation of one certificate. On our COVID-19 round site, you can look at previous presentations. And last week, we were talking about COVID-19 and respiratory disease. You can see that today's presentation, the slide set that we'll be using is already archived for you, and that will be available to you moving forward. This clinical resources button here will take you to the NOSM online clinical resources. And I'd just like to point out to you the case status for Northern Ontario as of 11 o'clock this morning. We now have 220 cases of COVID-19 in Northern Ontario, although the majority of them have recovered and resolved. Of importance, we now have 9 cases of COVID-19 in Northwestern Ontario in 3 different Indigenous communities. And of this total of 60 COVID-19 cases in Thunder Bay and area, approximately 15 are related to an outbreak in the Palladium mine just north of Thunder Bay, and that's a major concern. On the website here, you'll see various resources. And in particular, there will be resources that are relevant to the presentation today in the area of resilience and wellness. And the other area in particular to point out to you is the area that gives you resources for supervising and teaching your learners. So again, feel free to visit the site. It's updated almost daily and a good source of information relevant to Northern Ontario.
Ready to step in here, James?
I'm just going to share another slide. Thanks, Jack. Almost there. Our planning committee has no conflicts of interest to declare, and there's been no sponsorship for these COVID-19 rounds. Really want to emphasize to people that our knowledge of COVID-19 is rapidly changing, and our presenters will be discussing the best available information currently available. Throughout our presentation today, please push your questions or reflections via the chat feature in WebEx, and your questions will be relayed to the presenters during our question period. If you are phoning in, you have an opportunity to push questions using our CAPD email address there. Just a little reminder, if you can maintain yourself on mute and turn your video off, as that will improve both the sound quality and the picture quality for the rounds today. Wanted to share with you a graph that is circulating right now, and I think it has a lot of importance to our session today. As you can see, we're looking at the impact of the COVID-19 pandemic or the health impact. You can see that we are presently in the first wave, and we're dealing with both mortality and morbidity related to COVID-19. We're already seeing some of the impact on the second wave with restriction of urgent cases. Most of our hospitals are not doing elective surgery, and most of our hospitals are only dealing with emergencies. You'll see over here, which is really the 4th wave, and this is the wave that we really will be talking about in lots of ways. We are in the midst of the 4th wave already, but the 4th wave is really looking at the mental health impact of COVID-19 both on our patients and communities, but also on our healthcare force. I'd like to introduce our team for the presentation today. Dr. Jack Haggerty will be moderating, and then Jack will introduce both Diane and Stacey, who will be presenting a part of the question panel. Jack is an adult psychiatrist in Thunder Bay and is involved and interested in a range of psychiatry areas, including shared care, telepsychiatry, and outreach. Although Jack practices in Thunder Bay, he also makes regular and multiple visits to communities across Northwestern Ontario. Jack, I'll hand it over to you to introduce our presenters, and thanks so much for moderating today.
Thank you, James. You can hear me okay, I'm assuming?
Sound is great.
Welcome, everyone, and I look forward to a very active discussion over the next better part of an hour or more, and the opportunity of being a facilitator of two excellent individuals that will contribute to our knowledge of the fourth wave that was really nicely graphically displayed there. So thank you for that, Dr. Kurtzen. I'm going to introduce first Dr. Whitney, and I think Stacey Rolls I will introduce at the completion of Dr. Whitney's talk, as we discussed earlier in our preparation. Dr. Whitney, Diane, is a colleague and a friend, is a community psychiatrist in Thunder Bay, but has been for a number of years the program director or lead of the postgraduate training of NOSM Psychiatry. She has several academic positions, both assistant professor here at University of Toronto and adjunct professor at Western University in London. Her areas, for those that know her, have been involved with mixed anxiety and mood disorders, psychological trauma, and women's mental health and trauma. Dr. Whitney served in the first Persian Gulf War in 1990-91 and has been an ongoing advocate for physician well-being, as well as a strong proponent of education. I'll move on to, at the completion of Dr. Whitney's talk, to introduce Stacey Rolls subsequently. So, Dr. Whitney.
Thank you, Dr. Haggerty. Okay, can people hear me? Are we good? Okay, we're good. Okay, thank you. So I'm going to give the main bulk of the talk this afternoon, but certainly Stacey Rolls has made a contribution to it as well, and as a collaborator, and she'll speak near the end about some of the resources as well. So I think this is a very important topic, and I think Dr. Gertsen's graph shows the mental health component, the economic and social issues that play a role. And as this pandemic continues, I think the social isolation continues, and I certainly begin to feel with my patients that I'm hearing a lot more about cabin fever as warm weather, and how long is this going to last? Lots of questions that need to be answered. Next slide, please.
Sorry.
Okay, that's okay. Technical problems, that's okay. There we go. So the next slide is teaching objectives, and what we're really wanting today to do is highlight what the impact of COVID-19, and also I think the social isolation, just as importantly, is on people's mental health. Share with you a little bit about the scientific literature, focusing in particular on healthcare providers and the impact. And then overall provide you some tools to support your patients, yourself, your colleagues at this time. And I've got a couple models at the end that I'll share with you, and a couple tools that I hope are takeaways. So next slide, please. So as the social isolation progresses, we're well now past a month, the mental health impact emerges more pronounced. I think in my clinical work, I heard a lot of anxiety in the beginning that still persists. And looking at, in Canada specific, it's a benchmark, a mental health score that's used. But the usual average sort of sits for the country around 50. In the last several weeks, it has increased based on polling and people's results up to 75. It's a bit of a business model. And another survey is done that reported that 83% of Canadians are concerned about the impact of COVID. One study I found from the UK looked at about 20% of the people specifically concerned about mental health, mental illness, being more pronounced in women than in men. So the next slide as we get started, is certainly what we see is anxiety and uncertainty being sort of the infectious mental health component of this disease. So we see it in the general population of people worried and concerned and uncertain. And then we also see it in our patients. So I've seen some of my anxious and depressed patients be more anxious and more depressed and more immobilized. A few of my patients have said it means I don't have to go out, so they've actually have found this a little easier for themselves. Worrying about psychotic patients relapsing. I certainly have had two patients with bipolar mood disorder have mood fluctuations and hypomanic symptoms during this time. So what you tend to see is an increased anxiety, increased maladaptive coping strategies, suicidal ideation, and dealing with that over the phone during a phone appointment is a challenge. So that's what you see, I think, in the clinical population. And we as mental health providers, healthcare providers in general, play an important role, in educating the public. I never thought I'd be so much a resource of information about COVID. And I think the most common question I get asked by most patients is, "Hey doc, when are things going to open up? When's society going to open up again?" The next slide. So in addition to the anxiety, seeing lots of difficulty with sleep, difficulty getting to sleep, falling asleep, people's routines and schedules are not the same. So that certainly emerges. Fear of illness in themselves and in family members and friends. And for some people, an increase, and this has been substantiated by some studies in Canada, of increased drug and alcohol consumption, partly to cope, partly out of boredom, partly out of unstructured days. And you may see reactions in children. I'll have more to say a little later, but children may regress and act out as well. The big part is providing education, informing families and patients where and when to get help, where to get basic information and support. And as this period of isolation extends, what I've seen in my practice, I would say the first 2 weeks was very predominantly anxiety, and now what I'm hearing is anxiety related to finances. So I did a little bit of research on the human resources side, and they report that 49% of Canadian workers describe COVID has impacted their employment. So that's half. Half have lost a job temporarily or permanently. More commonly temporarily, have been laid off, but still there's been about 10% of the workforce has lost their job, right? And another 18% say their hours of work have reduced. So a very small percentage of the population, their hours have increased, probably in certain places like the grocery store is what I'm hearing. So a lot of conversations I find around who's working, who's not working, what's the impact. And financially, what we know from the studies is that 6% of homeowners have missed a mortgage payment and 14% of renters have missed a rent payment. So I think we're seeing the financial impact at this time and the effect it has on our patient population. Next slide. Managing the anxiety, this is a high level, and we'll give you some more specific tools a little bit later, but acknowledging to people that some anxiety and fear is normal, to be expected. That people can switch off the technology and do something more enjoyable, just watch the news or be preoccupied with their phone. Being active. I had many interesting conversations about how do you exercise in your own home environment. It can be done, right? Being careful what you watch on social media, watching your news intake as well, and redirecting patients to reliable sources of information. As a society, looking after each other, checking on your neighbor, checking on those at risk. It's interesting about hoarding behavior, and I think the toilet paper story that's being part of this COVID, our common responses in times of uncertainty. Your brain's engaged in a fight-flight response, and that's what's feeding, whether it's your hogging toilet paper or other other things in the economy. Next. My next slide is about children. I'll make the premise that I'm not a child psychiatrist, so my advice is general, right? But it is really important to pay attention to the children and making sure they understand and are reassured in an age-appropriate way, acknowledging their fears and addressing their risks and their questions, right? Limiting social media time, limiting TV time, helping adolescents understand the social distancing, the reasons for it, and what things not to share. And over the last, I would say, 5-6 weeks, I felt like I'm back to being a family doctor in my roots. I've given advice to one patient on toilet training their child when she asked me, and another patient asked me about managing acting out behavior in our autistic child as well. So, I mean, we sort of go back to our roots and the basics and help people manage things. Next slide, please. The next couple slides are specific about at-risk populations from a mental health point of view. The seriously mentally ill comprise 3 to 5% of the population, and the homelessness and the group living certainly make an increased risk of infection and spread. I was reading online yesterday some of my U of T material I have, and it was the dean of medicine, Trevor Young, who I know quite well, speaking about the spread in the homeless shelters in Toronto, which has been quite significant. So these people often have coexisting medical problems, and if they get admitted to hospital, there may be an increased risk as well. With addictions, I mean, most of the supports for addictions are limited at this time and only online, but people can access them online. If you don't, that's a problem. And if we do ever close the liquor stores in the province, are we going to have, a risk of addictions as well? And what people use to reduce their risk is structured time, activities, and these are gone. Just out of interest, I had one patient who didn't have an addiction history, but was actually using a daily AA support group to actually organize her day. So we agreed on that. Next slide. Population is those people living in domestic violence situations, the social isolation increasing the risk of victimization, programs not operating, women's shelters being at full capacity. And so I think it's less likely to be identified of what's happening in the homes, and the young children and youth are victimized as well. I think that's one area why I'm quite concerned as this goes on longer. So are some of my at-risk patients. Next slide, please. The next slide looks at the risk of suicide. And I mean, I think this is something that's really quite key and important during this time. We know in general, if there's an economic downturn, that it's associated with a higher risk of suicide rates. So certainly if you have almost 50% of your population out of work, I mean, that certainly increases the risk, right? And that social isolation, if people are cut off from other people, that increases the risk of suicide and associated with suicidal thoughts and behavior. And if you have trouble getting to your mental health appointments, or they're not happening, or your family doctor isn't as accessible to you, that's certainly a barrier. Decreased access to community supports and religious supports. A statistic I didn't know until I was reading this paper, was that weekly attendance at religious services is associated with a 5 times lower risk of suicide. So if you can't get to your religious service, and how you lose your support, or even your AA group as well. And finally, we know that there's an elevated suicide rate among medical professionals at any time, and there's certainly been reports of suicides of healthcare providers. And, several in Europe, where there was COVID positive, and concerned that she had infected her patients and committed suicide. Financial issues for healthcare professionals. There's lots of things that could contribute to that group as well. Next slide. So what can you do? This part of the talk will give a layer of what can you do, and then we'll come back to it again at the end. And they may sound like motherhood statements, but they are important things, helping people have a healthy and balanced diet at this time, minimizing or reducing alcohol and cigarettes, I think sleep hygiene is essential. I'm working practically with people. I've negotiated with 2 patients how many showers a week they were going to take, because they were actually taking care of their own hygiene. Establishing a daily routine. I have a friend who's a physician in Ottawa, and first, I think 5 days of the pandemic and self-isolation, she hadn't taken a shower. She hadn't even taken her dog for a walk. So I don't assume, even with usually functioning people, exercise of some type, yoga, tai chi, right? And engaging in something in a meaningful purpose or accomplishment. And I think that's hard for people who aren't working at this time. The next is a tool. It's a grounding exercise that brings people back into the present. So the idea being 5 things that you can see and actually naming them to yourself. 5 things you can feel, feeling the arms of your chair, the texture on a chair. 3 things that you can hear, hearing things in the environment. 2 things that you can smell, and 1 thing that you can taste. So it's a structured activity, but to bring people from a higher level of anxiety into a current, so here and now. Next, and in a mindful way, is also looking at things that are pleasurable that we can actually do. And we've got Stacey's got some created some lists coming up in the next slide. But it's things that we do that we enjoy, right? And mastery is things that we do to gain a sense of accomplishment, right? And that may be a practical sense of cleaning out your closet, which seems very popular right now, or even just something small like baking a cake or doing some baking. And trying to combine both things that are both pleasurable and mastery are within your day and over your days. So the next slide is both pleasurable and mastery activities, but just ideas for people to use. And at the very beginning of this self-isolation, my 15-year-old niece from Southern Ontario actually sent me a link with a list of things that you can do while you're on social isolation. There's lots out there, and I think you have to modify them for yourself. The next 2 slides, I'm going to ask Stacey to comment on some of her contribution to the presentation.
Hi, everyone. Thank you, Diane. This first tool is accessible to anyone. It's written in plain language, and it really walks people through the difference between rational worry or excessive worry. So what I'm seeing a lot in my practice and in a lot of the groups that we're running is that people are being bombarded by the news, of course, and wanting to wash their hands and do all these things, but then they're having a hard time monitoring when that's appropriate, say when they're at home. So if you're at home, do you have to wash your hands every 10 minutes? Probably not, right? This tool really helps walk us through how to maintain that balance, what's an appropriate type of worry. It goes into the pleasurable events, the mastery events, and other things that you can do to help manage your worry. And then it also goes through some cognitive behavioral therapy type thought records and ways that you can challenge some of these difficult thoughts that we might be having. So that one's accessible to everyone, and I'd suggest that you check it out. It was from Psychology Tools put it out, and it's really well done. The next slide is another COVID helpful tool. It was created by Russ Harris, who wrote The Happiness Trap. So he's an acceptance and commitment therapy person. He also does a lot with compassion-focused therapy. Another tool you can give to your clients or your patients or try for yourselves. And really, it's looking at the acronym FACE COVID. So it says focus on what's in your control, acknowledge your thoughts and feelings, come back into your body, engage in what you're doing, committed action, opening up, values, identify resources, and disinfect and distance. And then it runs through how to do each of those things. So a really helpful tool, again, that you can hand out to your patients or use yourself.
let's repeat. So if you could just move it ahead one more slide, James, that would be great. So the next piece we're going to do is talking specifically about healthcare providers, and the next slide just touches on some scenarios of the reality of life situation, the whole aspect of triage and access to care. I mean, I also use this slide for teaching with the residents, and who decides who gets the last ventilator, if that's what your capacity at. If you're a medical physician, if you're a psychiatrist, and Dr. Chang and I were debating who'd last intubated a patient if we had to. We hope that we didn't, but what things can we do? But I've done a little bit of medical prescribing during the pandemic for some patients that couldn't get access to their family doctors. The whole aspect of if a colleague or a number of people within a workplace, a hospital, or speaking to a police officer is what happens if someone is exposed and then has to wait for testing. We certainly saw that in Thunder Bay over the Easter weekend, and commonly the issue of risk to yourself and your family comes up as well. So the next couple of slides actually look at a few studies. The first study is from JAMA from March of 2020, and looking at the pressures on people in the healthcare workforce, the whole aspect of overwhelming burden of illness. And I think probably New York best emphasizes that. The risk of infection and the whole aspect of risk to yourself and those that you know. And then the high risk clinical settings as well, the ICUs, and some of the pictures coming out of the ICUs are pretty daunting. Next page. So this study looked at Chinese healthcare workers, and they had over 3,000 healthcare workers infected during their first phase of the pandemic, with at least 22 deaths. The major concerns were access to PPE and cleaning were the main. And with mental health, they commented that their planning wasn't adequate. There wasn't a connection between community and mental health institutions, and a shortage of various mental health professionals. But also sometimes then on the other side, mental health professionals not being considered essential. And some of the data I have from the States is it's estimated that 10% of healthcare workers are infected. In the US, this is data from a week ago, the 27 healthcare providers had died from COVID, and 10 of them were over the age of 65 in that setting. And it would be very interesting to know what the rate of infection is, from long-term care facilities. Next slide. This is a more recent article from JAMA, and they actually did a survey of 1,257 healthcare workers in China in January and February, with a high participation rate of almost 70% during the pandemic there. Most were women and more nurses than physicians. And they used simple scales, but it's amazing. It's interesting to look on the next page what they had. They used a PHQ-9 for depression, a GAD-7 for anxiety. They had an insomnia inventory, which I hadn't seen before, and then an impact of event scale used for trauma as well. And if you the next slide just shows the results. I just kept it simple, but it showed that those working in Wuhan, China, had more severe degrees of symptoms on all measures, especially nurses and women. And listed below, looking at the depression and anxiety, the most strongest that you see is insomnia at an odds ratio of 2.97. And the others are still significant, but that stands out. I think that that's probably, given my past experience in the military, it's often a marker or a precursor or sort of early warning sign as well. Next slide. So people are aware there's a cohort of mental health therapists in Ontario formed a network, and this is their website. And frontline workers, healthcare workers, and police paramedics can actually refer themselves. It's actually a nice website to the organization, and then they match them up with appropriate counseling that's free. That the therapists are donating their time. So I think it's a good resource to have on your at your hands for healthcare workers and frontline providers. Next slide. So next, I've got two models, interventions, and then I'll pretty well be finished. But next slide. One slide. This is from a study looking at SARS from 15 years ago, emphasizing how to mitigate the impact on healthcare workers, which includes clear and rapid hospital communication and frequent communication. But I'm certainly hearing in SARS, the problem I'm hearing is often the communication changes daily what the expectation is. Having good leadership at multiple levels, having good hospital processes, having a form of psychological support informally, and then also telephone lines and drop-in centers. And next slide is just it discusses the impact of self-isolation and quarantine on healthcare workers, symptoms of PTSD and depression, stigmatization, fear of loss of income, and the need for a strong social support for those people while in isolation, and actually practical supports. In the psychiatry program, I had two residents over the Easter weekend who were potentially in contact with the COVID patients. So we had to sort of put this in place over a long weekend. And one of the simple things I realized is the program didn't have a clear list of everybody's cell phone number or home phone number easily accessible. So how to provide these supports. Next. What I wanted to talk a little bit about is two different models of dealing with symptoms or dealing with distress, dealing with stress. They're not necessarily psychiatric models, but it's about educating people how to understand that being stressed or stressed, and having a reaction to an abnormal situation, is normal and expected. And how to help people manage the stress and increase their resiliency. So the idea being improving short-term performance and long-term mental health outcomes, and eventually barriers to care. So the next slide shows you, this is a program called Road to Mental Readiness Program. And I'll confess, yes, it is a military program designed for the military initially, but has also been used by the police. It was developed by the Canadian military for Afghanistan in 2008. And helping people both get prepared to Afghanistan and then maintain themselves there. Next slide. So the idea is a mental health continuum. On the left being healthy and functioning, and then as you move more to the right, you become more reactive, you're having trouble sleeping, you may be having nightmares, you may be more irritable, and you're ill when you're on the right side, which would probably be called combat stress reaction or acute stress reaction. And people move back and forth along the spectrum, particularly between the healthy, reacting, and injured as well. But it's basically a continuum. Next, I'm just going to show you a little bit about the app. I apologize, the quality didn't quite come out on the slides as I like, but when you open up the app, this is what you see. The mental health continuum is the second one down. It actually allows you to monitor your behavior, and then it has other tasks that are listed there. So if you move on to the next slide, it shows you what you can monitor. You can monitor your mood on a daily basis, the amount you're sleeping, your physical symptoms, your social behavior, how much you're drinking. I mean, it's a tool to be designed for self-monitoring. And I think it's a useful tool. And then next. Come back to the continuum, then the bottom of this slide, I know it's a busy slide, but it really shows you what interventions you need to be doing at different levels. So if someone's in a healthy range, focusing on the task at hand, breaking down problems, using some breathing, developing a support system, and the more higher up you go, the more intervention and more mental health into the injured and ill section. Next. The other thing this program talks about is actually some tools. So using goal setting, SMART goal setting, which most of us probably know, using some visualization, using some self-talk, using some breathing exercises. They call it the Big Four. It's the language they use, but it's an interesting tool that you could recommend to patients. The other tool that I want to just briefly mention is it was actually launched this week in Canada, called Wellness Together Canada. And so Wellness Together Canada is actually designed by the Canadian government nationally. That's a portal that has someone complete a survey on symptoms and well-being and impact of their mental health on their functioning, and it creates a score for distress, well-being, and functioning. From that, actually, once you get the score, and actually different interventions pop up that you can actually use to actually address your stress, your distress, including things like mindfulness techniques, online courses that are cognitive therapy focused, and also some other ones for substance abuse. So it's well worthwhile looking. I think if you're looking at looking at things for patients, of some tools that they can use and intervene. And I think next slide. And I mean, this is the last slide, and then we'll do questions and I'll ask Stephanie to address it. But just really knowing what resources are available in your community so that people can access them as well. If you have any interest in the tools, I'm more than happy to speak to people individually as well.
Thank you, Dr. Whitney. It's excellent content there covered, and I know we want to have a time for Stacey Rolls to speak, and then we'll bring it back. And I do note that the chat, if you click the center point that has the chat access, questions can be submitted. I'm going to introduce Stacey, who's a cognitive therapy certified consultant, credentialed with the Canadian Association of Cognitive Behavioral Therapies. She's done advanced training in supervision and exposure and compassion-focused therapy. She's an advanced practice nurse, which I thought was a nice to see as well. And an adjunct professor at Laurentian, lecturer in psychiatry at NOSM, and has had extensive experience working with Indigenous population on Manitoulin. She's the lead consultant on the Structured Psychotherapy Initiative in Northeastern Ontario, and she is the lead for CBT Training Center for the Stacey Rolls and Associate Psychotherapy Services. So welcome, Stacey. I would welcome any comments or additional thoughts, and then we'll open it up to questions.
Thank you so much for the introduction. I also am open to being contacted if there's any questions about the resources that we discussed. There's just a few of them listed on that last slide, but there are many more. One I just want to make note of that I thought was a great idea was the seniors voice line that was on that second last slide. And it's a friendly voice so that seniors who are maybe feeling isolated and can't have their visitors, particularly in long-term care facilities or wherever they are, can call and just chat with somebody. So I thought that was a nice one that I found that I just wanted to mention on that slide.
All right. Maybe I'll stay with you, Stacey, for a bit. Many of us online are some of us on the talk will be care providers, and what would, I think we tend to be helpers of others, the care for self. What would be kind of at the top of your list of the self-help strategies? Diane, Dr. Whitney covered a number of them. What would be the things that you would recommend that us as care providers to kind of go to first for our own support and sustenance?
Yeah, well, definitely, there's a couple at the top of my list. Reaching out to others is so important. So being able to have colleagues that you can talk with, confidentially about what you're experiencing, so that we're trying to keep the vicarious trauma and some of the, resulting PTSD that might come out of this at a minimum, right? So the more we're reaching out, the more we're engaging, processing some of the things that we're going through. It's a difficult time. We know that rarely are we treating something that we're also living through. So we need to recognize that in ourselves, that our anxieties may be higher than normal, and now we're trying to help people who are also bringing anxieties to us. So, talking that through with a colleague or with, supervisors or whoever it is that you're working with. The other thing is really moving your body. Like we end up building up so much adrenaline with the flight response that if we're not burning it off, it can really just sit with us constantly, and we don't want to stay in that state of unrest and nervousness. So the more you can move your body, burn off that energy, that's what it's built into your body for, so that you are ready to fight, flight, or flee, right? So if you can burn it off going for a run or a walk or doing some yoga, something that's going to help you engage in some of your deep breathing, that can be very helpful for you as well.
Great, thank you. And again, I remind those that are on the talk to enter questions into the chat section, which is the blue kind of quote icon there. Diane, can you comment on what would you think would be the top 2 or 3 primary care presentations that someone may come in and that you would think would be kind of a common complaint and a management strategy, if you want to reiterate some of those from a primary care perspective?
I think some primary care patients will just come in and say, for instance, they're feeling anxious or they're not sleeping well. Sort of put those, 2 together, and it can identify it and can say it's related to COVID. So I mean, acknowledging the anxiety, acknowledging the normal response. I think it's a time to bring out your sleep hygiene skills with your patients. Out of these, and I think things are different. People aren't, for instance, getting up in the morning at the same time, and encouraging people to develop a routine and be very practical. What time are you going to get up? What are you going to take a shower? Are you going to walk the dog? I think are really key. I think concerns about others, and I think I certainly felt in my practice, I have a lot of female patients in my practice, concerns about their children. Right, that's how I got the potty training question. Okay, right. But I mean, the reality is and everybody's in an intense environment at home. Is child rearing, right? Questions, and I think helping people, people address that. And then I think the other common presentation in primary care would be if you have people with pre-existing conditions, checking in with them to see if their symptoms are worse, in any way, and how can you manage those symptoms, not necessarily medicating them, but trying to do symptom management.
Okay. One more question for you, Dr. Whitney, before I pass it over to Dr. Gertzen with a question. Can you comment on the domestic violence that's been raised at a national level between some of the academic chairs, and it really kind of came on my radar when it was raised there. What's exactly happening there? Is it that couples are just in each other's proximity too much, or can you give me a sense as to what's unfolding and any suggestions for increasing our attention to those?
Well, I think because just in couples and relationships together, people are spending a lot more time together, so there's the risk of disagreements and quote unquote getting on each other's nerves, right? But then with the domestic violence, with a couple of my patients, the degree of the control is increased within the relationship because they can't even get out, to say to work or to other things that they do. So there's even more of a sense of control. And then you add in financial difficulties if somebody loses a job. All these things to me that in a simple way, fuel the domestic violence, fire, relating to social factors. I think during this time, I think we just need to be more aware, keeping it in our mind, and asking patients how they're managing living together with someone, and going over, reviewing safety plans for women to exit the home. That's hard to do right now. I think that's one of the biggest challenges in that way.
Yeah, thank you. Dr. Gertzen.
Question maybe for any of you to answer. If I sort of look back in March, we were sort of in the preparation stage as healthcare providers. We had a lot of anxiety. There's fear of what was to come. There was sort of this frantic preparations that we were doing. We were preparing for the sickest patients. Would we have a repeat of Italy and New York in our in our setting. And now that it's a month later, I'm just wondering, are we really moving into a phase where we're still dealing with the unknown, but are we going to go through a bit of letdown? I mean, we really were fired up and really focused on doing things, and now we're sort of in that phase where it's not been quite as bad as we thought in Northern Ontario. There's still been disruption. We're still apprehensive, but maybe we're also going to be let down a little bit for all this prep. I mean, just wondering whether anyone would comment sort of on these phases that we are going to as healthcare professionals, and how best to recognize them, how best to address them. Jack, Diane, either of you?
It's Diane here. I mean, I think we haven't reached our peak in Northern Ontario. I think it's one thing we have to be careful about. You know, and I think this is not just a single battle. This is a war. So if things actually do slow down, you know, how we pull back is a decision of some people, but we pull back also psychologically, but we also have to prepare for the next round or the next wave, right? And to me, I'll use my military background, and having spent 5 months, you know, 3 months in a war and 2 months preparing for a war, you know, you're not at, you know, you have ebbs and flows, and you have to sort of get used to that you're not at peak performance, peak readiness every day, you know, and I think that, yes, there can be a bit of a letdown, but the reality is we're going to have to prepare for the next wave. And if you believe the CDC in the States, you know, that's going to be influenza and COVID later this fall or early winter.
Thank you. Back to you, Jack.
Sure. I maybe I'm not sure if Stacey or Diane want to comment. There's a few initiatives, some of which you've presented, that are online access. Do you want to maybe comment, Diane, on e-consultations and that's availability through to any nurse practitioner or primary care provider as a additional resource, maybe bounce back as well, that Stacey maybe comment on in addition? You maybe want to comment on those briefly?
So the e-consult is a consult, electronic consult is available to primary care providers on an ongoing basis, but more of a diagnosis and treatment recommendation. I mean, so it can help with sort of assessment and recommendations. I personally am concerned in the North that do we have enough counseling resources and supports to people? Right, and that's why I presented both these tools. You know, one a little bit more military focused, and the other one, it came out this week. I didn't even have a slide, but I'm really actually quite concerned of, you know, how do we support people emotionally and psychologically, and are people willing to use those tools? One of the things that I found, and I spoke to a colleague psychiatrist in Sudbury, we're surprised how few people actually had access to computers to do e-visits on from their home for psychiatry. I would say only about a third of my patients are able to do that over e-visit, right? Where I can see their face like this versus, you know, doing the telephone. I find the telephone stiff and mechanistic, you know, so I mean, you know, I think in Northern Ontario, access to counseling, access to computer resources it can be limited, right?
Yeah. Stacey, any additional comments?
Yeah, I absolutely agree with that. There are two great programs, Bounce Back and Big White Wall, that people can access. But yeah, again, it's a lot of people lack computer access. A lot of people are lacking proper internet access. You know, it can be a really big barrier, and our public systems are still running. Most of the like in Sudbury, for example, with HSN, the mood and anxiety program is still running, but it is mostly through telephone contact, then through computer contact. But I think, you know, we are going to see that shift in what happens with mental health services, because as those programs are typically running with groups of people coming in and being serviced at the same time, now they're going to individual contact. So, you know, we may see an impact from that as well. I think, you know, it's really important to look out for the other resources that do exist. We've been running, my private practice has been running free groups, psychoeducation groups, just 3 per session to help people deal with the anxiety around COVID. So we've ran that twice. They filled up right away. And we're running one for first responders as well for free. So, I mean, a lot of people are reaching out. There's a lot of people helping, but sometimes just getting, the word out that those things are going on is some of the most difficult pieces of this. So as physicians, I think if you're checking, the resources that you guys are posting here, I think that's a fantastic site so that everyone has the information all put together. And I'm definitely going to be accessing that a lot more now that I know about it. So thanks for that. Yeah.
Again, kind of last call for questions coming in on the chat line. Maybe I'll just throw out one more post-pandemic. Stacey, I'll come to you first. What's the new world? What's the new mental health perceptions? We're going to be all more comfortable being used to the phone. Can we give up our offices, or are we just going to go back to status quo and things as usual? Where do you think we're going to be, in 6 months, 18 months time?
Yeah, I think we're going to see a lot of changes. This has created a shift in how we provide services from, primary care to mental health care. So there's things that, yes, we probably can do on the phone, or there's things that maybe don't require as much of a face-to-face connection. But there's other things that we definitely know people benefit from that contact and socializing with one another. So I think it's going to shift a lot of things. I think it's going to make services more accessible once we figure out how to go about doing that. So in remote and rural areas, using more technology in those areas, maybe seeing the need to get hubs put in place so that people can access proper internet and computer systems and things like that. And so I think there's going to be a big shift. But we talk about this new normal, and I like to think of this as a time where we can set up what we want our new normal to be like. So this has given us a lot of time to reflect on, our families, how we practice, psychotherapy or medicine, and how we want to set up things for our future. And we have that time right now to reflect and maybe make some changes that we've been wanting to do. So.
Great. Last question, Dr. Whitney. As Governor Cuomo said, we had our 9/11. Everything changed. Airports are, security never looked back. And are we going to? What is it about the legacy of this pandemic at a mental health level? Do you think will be, or do we even know that will be different? Will we look back as being things have changed forever, or do you? And if it's going to change, what are those changes? Do you think?
Thanks, Jack. I think I have a couple minds there. I mean, I'll be honest, after SARS 15 years ago, I don't think things changed for mental health that significantly. People just went back to doing face-to-face. So, I mean, that's one piece. I think our patients are going to demand more access by telephone. And I use the e-visit through OTN because it's secure. And I was actually using the e-visit through OTN before this, actually, reaching out to people like in Nippigan or Fort Francis that had the technology rather than actually having to go to the hospital to be seen over OTN or having to come to Thunder Bay. So I'm hoping we're going to maintain some of that adoption of the technology. The other question is the OMA actually though going to continue to support is the government going to support the phone codes? Because the phone codes aren't supported financially, that's gone, right? I mean, so I think there's an opportunity, but I think some of the inertia may fall back to what we were doing before. I'm quite worried about an increase in first responders and healthcare worker referrals, and I haven't seen a lot of that yet, but I think it's going to come. And how are we going to manage those people as well? So I'm hopeful things will change. I think the patients are going to demand it, but I still think there's a value for face-to-face.
All right, looks like we got maybe time for one more. Stacey, if you want to take this one, managing grief and loss during a pandemic. Any thoughts you want to throw in before I pass it back to James?
Yeah, I think, most of us are going through some form of a grieving process right now. The sense of uncertainty, so the anxiety is coming up, but really we're grieving the loss of our lives as they were right now, right? And whatever it looks like for us. So that may have hit people very hard around Easter, the lack of social connection family and friends, our jobs, the pieces that gave us meaning and purpose. So there's a lot of grief and loss happening in our regular day-to-day. And then when we add on to it, if we know people who have been impacted by this, like who have contracted COVID and all of those things that go along with that, or if somebody, unfortunately, that we love or know passes on. So there may be a complex grief response through this. Again, like Diane said earlier, having these anxieties and going through grief response is a very normal reaction to an abnormal situation that we're all living through. So checking in, making sure that it's not going into the state of excessive worry or excessive grief or excessive depression. And if it is, really reaching out to your physician, your psychotherapist, your nurse practitioner, whoever it is that you see, and getting that support and help.
Great. Thank you. All right. Dr. Gertson.
Question just to throw back at the three of you. We're in the midst of COVID. How are we training students and residents in the area of mental health right now? With the elimination of a lot of face-to-face patient contact. So wondering whether either Jack or Diane could comment on, how are you precepting right now with residents?
It's Diane here. Psychiatry, I mean, it has changed some, but a lot of the residents actually honestly got their own OTN account and are seeing patients over OTN. And one supervisor and one resident are actually sort of doing a parallel schedule and actually setting it up so that both the psychiatrist and the resident can see the patient together. So, and then also using the technology, and going back to the basic technology, the phone. So we've been doing that. There has been some decreased volume in the acute care hospital, but that seems to have picked up this week. And because, of course, it had to be my program, but my residents have had 3 educational sessions on COVID-19 and mental health. I mean, I'm willing to do it to assist with any other program if people are interested, because I think it is relevant. I think it's helpful to have the residents thinking on their feet and talk about these things. Give them some tools too, because they're talking to patients.
The only thing I would add, James, I think NOSM and Sarita have done a good job, I think, at bringing to kind of the collective, kind of the teaching group, shared information that has been both undergraduate and postgraduate and faculty. So I think we've, understandably, there's a bit of a chaotic state for our first couple of weeks. We were scrambling to get a pandemic plan together, making sure if we had a surge, we emptied the hospitals out. So there was a lot of chaos, and it was more by observation as to how, for those of us that had some composure, and I think it waxed and waned in all of our lives, that I think it was more modeling and being there, having them participate, the volunteerism that came out of the students' initiatives. I think these were all signs of their kind of honor to their contribution. So was it ideal? Was it perfect? No, but it certainly was a presence. I mean, to me, where we're going now, how do we re-engage? I think that'll be a challenge for the med school to optimize that next step. So those are my thoughts, James.
Thanks so much, Jack and Diane. I'd like to thank all 3 of our presenters, Stacey, Jack, and Diane. Just a reminder to our audience today is please complete an evaluation. We really want to get your feedback on our rounds today. And for either healthcare professionals or physicians, if you would like study credits, there is a way to do that when you complete your evaluation, and the evaluation will take all of 3 minutes. Join us next week on May the 1st, when we're going to be looking at COVID-19 and pandemic palliative care. We've got a wonderful team of presenters, including, and I'll just use first names because they're all first name basis with me, Kevin and Kevin, who are involved in palliative care in Thunder Bay. Francis is involved with palliative care on Manitoulin Island, and Christine, who's involved with palliative care in Sudbury. Thank you everyone for attending. Please look after yourself. Please stay safe and do something kind this afternoon to someone. See you in a week. All the best.